So, this chapter, I feel, of your book about initiating and adjusting invasive ventilatory support really does a nice job of covering, again, a lot of the information that we've been learning in, chapter 46, 47, and 48. And then kind of applying it to specific patients. So that I don't feel like there's a lot of necessarily new information that gets covered in here, but a lot of information to help kind of tie things together for you and understand how we decide on initial vent settings and how we make adjustments to our mechanical ventilators. So obviously, you guys all probably feel this by now that mechanical ventilators are very sophisticated. There's a lot of technology in them. There's a lot of moving working pieces that you kind of have to understand because making an adjustment to one thing can have an impact on a different type of setting. And again, this is why I think it's so very, very valuable to have people like you guys who are going to school for this and focusing so much time and energy on making sure that you understand some of the complications and hazards that can happen with mechanical ventilation, and understand what kinds of criteria we are looking at when we're picking our initial settings. All right, so just some objectives here. This lecture is going to be two parts. In the first part, I'm going to be kind of covering your chapter up to when we start talking about adjusting ventilation. So this will be pages 1072 through, where am I going through? Oh my goodness, I had it highlighted through kind of the top of 1087. So this is what we're going to be covering in part one, up until the section on adjusting vent support. All right, so again, kind of our little introduction here just talks about, the fact that this is a sophisticated thing. What we're responsible for doing, our goal is to help with tissue oxygenation and removal of that carbon dioxide from the body. So that ventilator is going to be moving air in and out of the lungs to help facilitate this. So a lot of our decisions about initial settings have a lot to do with the patient's lung physiology, whether, their clinical state. So whether they're here for asthma versus here for ARDS, you're going to be choosing different settings to help accomplish our goals of oxygenation and ventilation. All right, so the book starts off just talking about goals of mechanical ventilation. So there is a box 49.1, which is on the top of page 1074. So it talks about the importance of supporting and manipulating gas exchange. So you guys have all been exposed to the fact that we do ABGs on our patients, all of our critically ill patients, to understand their acid-base balance, understand the amount of CO2 that's in their blood. And based on if they have too much or too little, we are going to be making adjustments to things like their respiratory rate and tidal volume to make sure that we can kind of normalize their pH. So we're, kind of looking to maintain that alveolar ventilation so that we can kind of normalize our pH and PCO2. We're going to look to maintain that arterial oxygenation. So we're looking at those values like our PaO2 on our blood gases, our SaO2 or SpO2 for saturation, and then kind of putting those two things together in regards to like total carrying capacity of oxygen. Because remember, that is an important distinction. You can have a patient that has a very good partial pressure of oxygen, but due to issues with their hemoglobin, they can have a very low oxygen carrying capacity, and it can result in very little oxygen getting to the tissues. We're looking at Making sure that we increase end expiratory lung volumes, or your FRC, so that's your functional residual capacity, which we manipulate using PEEP, a positive end expiratory pressure. We look at reducing or manipulating work of breathing. So work of breathing is pretty much one of the main reasons that you get put on the mechanical ventilator when a patient's CO2 production or ventilation impairment increases to the point that the patient cannot overcome it by increasing their respiratory muscle effort. Then they're going to go into that respiratory failure and need mechanical ventilation. So once we put them on a mechanical ventilator, we want to make sure that we're adequately supporting that work of breathing by, giving them enough, if they're in like an SIMV mode, giving them enough pressure support, or if they're in, more of a full support mode, like AC or ACVC or ACPC, that we're giving them enough settings, or our limit is set to high enough value it's fully supporting those patients' needs, so that they don't have to try to compensate by increasing their respiratory rate. We want to kind of minimize any side effects. So we're putting the patient on the mechanical ventilator. We talked a lot in the last section about the fact that this is going to can result in cardiovascular impairment. So we want to do things to minimize the effects of that positive pressure on the cardiovascular system. We also want to ensure that our patient and ventilator are synchronous. One, because that helps reduce their work of breathing, reduces their agitation, means that they're going to need less sedation. Dysynchronies or asynchronies are usually a pretty big reason that patients require additional FiO2 or end up not ventilating or exchanging gases adequately. So it can mean that they're on the mechanical ventilators a lot longer. We also finally are looking to reduce any ventilator-induced lung injury by minimizing those pressures that we're applying to the lung tissues. So we're going to be talking again a lot about plateau pressures. I'm going to include some discussion, new terms. I think you're ready for new terms about driving pressure and how that impacts or affects lung injury, like barotrauma in the patient's lungs. All right. So the keys to that lung protection is to keep those plateau pressures less than 30. So I highlighted that because we don't want it to be less than 28, which is what the book says. But the ARDSNet protocol, which I believe you guys are going through ARDS right now in your respiratory disease class, or you have recently done that. You were supplied with the ARDSNet protocol. On there, it clearly states plateau pressure is less than 30. So that's why I've changed your book's reference to match the ARDSNet reference. That is the one that's more universally used, and the one that you are going to be questioned about on your MBRC exam, more likely. So better to know the 30 than 28. Driving pressure. So when they talk about driving pressure, and when your book's talking about driving pressure, it's talking about the difference between the plateau pressure and the PEEP. So really, again, this is that reflection of the lung compliance. The bigger the difference between the plateau pressure and the PEEP, that indicates the worse the patient's lung compliance is, the stiffer the patient's lungs. So pressure injuries happen in the lungs by going from lower pressures to extreme higher pressure. So big pressure gradients, big changes in pressures are what's causing a lot of the damage. So that driving pressure, where you have a large driving pressure of greater than 15, that's going to result in more lung damage to the patient. And it is also linked to higher mortality rates with patients, just due to the fact that it's injuring that lung tissue. It's an indication that the patient's lungs are extremely stiff and non-compliant to begin with. So if you have really, really high driving pressures being used, that usually means negative impacts for your patient. Our goal is to try to keep our tidal volume somewhere between 4 and 8 milliliters per kilogram for ideal body weight. We're going to talk a little bit more about tidal volumes because that might seem like a really big range to you right now. But we're going to talk a little bit more about, drilling down into whether you're setting your tidal volume at 8 milliliters per kilogram, or if you should be picking 6, or if you should be picking 4. How do you decide? We'll talk a little bit more about that later on in this slide deck. We need to make sure our PEEP is set at an appropriate level so that we don't have that de-recruitment happening during exhalation. So remember, PEEP, that's at pressure at our baseline during the expiratory phase. That's what's maintaining those open alveoli. Again, your driving pressure is the difference between your plateau pressure and your PEEP. So if I'm setting a higher PEEP, that might be better for my patient's lungs, because it's narrowing that difference between the plateau pressure and the PEEP. If it's improving my compliance, then setting low PEEPs and using higher, like plateau or PIP pressures. Avoiding asynchrony. So anytime your patient's asynchronous, that's, like I said, that's going to result in higher pressure needs, higher flow needs. So overall, a bad thing for management of patients on mechanical ventilation. Avoiding auto PEEP. If I have too much PEEP, or I'm having auto PEEP there, my patient's not going to be able to fully exhale, which means that that's going to negatively impact my CO2 removal. And then I need to make sure I'm maintaining the appropriate oxygenation. And by appropriate oxygenation, again, we're looking for PaO2 somewhere between the 55 and 80 range, which is mildly, or could potentially be considered moderately hypoxemic. But I don't know if anybody would remember this, but from CP Phys, we talked about as you age, your PaO2 levels do naturally drop. So a lot of your older patient populations, it's not abnormal to see PaO2s around 60, that mild hypoxemia 60 range. So that's not inappropriate for those types of patients. But I feel like the big takeaway with this is not trying to memorize these range and be like super fastidious about sticking within these ranges, but more of just being cognizant of the fact that under oxygenation is bad, but so is over oxygenation. So we don't want to have either. So, we talked a lot about, setting the FiO2 initially to 100%, which, I'm sticking to that recommendation unless there's something in the patient's history that says you can do less. But it is important to be weaning those FiO2s rapidly. This is that link again to that ARDSNet protocol. This should be familiar to you from disease class. So it really kind of talks you through how to change, where to set your tidal volumes, and then how to make adjustments. So here, it, like I said, it calls out and highlights the fact that you want your plateau pressure to be less than 30. I just, sometimes I know you guys get nervous when what I'm telling you is not matching up with what the book tells you. So I just wanted to provide a reference for where that information comes from, so you're not feeling like I'm just making stuff up as I go. Okay. All right. Ventilator initiation. So, when we make the decision to begin mechanical ventilation, you are, looking for, again, what kind of indications are present. This goes back to that first chapter that we did. Was that chapter 45 or 46? 45, where we talked about type 1, type 2 respiratory failure, so hypoxemic failure versus hypercapnic failure. So what are the indications present? Okay, so my goals for ventilation will be different whether they're getting ventilated or intubated because of a oxygenation issue, which typically then is related to shunting, which we remember from the last lesson. Shunts are where we have underventilated perfusion going to underventilated alveoli. So to treat this oxygenation issue, that's requiring mechanical ventilation, I need lots of PEEP, and typically I'm not going to be able to apply very big volumes at the beginning, right? Because it's usually due to decreased compliance, right? So in that scenario, I'm going to be picking faster rates, lower volumes, higher PEEPs. If it was a patient who was, let's say, a COPD patient and whose issue was airway resistance, I would be picking smaller rates, right? Because I need to make sure I'm giving them adequate time to exhale. I'm going to be picking shorter I times, so faster flows. I'm going to be picking still smaller volumes, but not as small as with ARDS. And I'm picking smaller volumes because if the more volume I put in, the more volume I have to allow time to get back out. So I'm still going to be picking volumes, but for a different reason than in the ARDS patients. I want to look at my options on whether I want to use non-invasive or invasive ventilation. So non-invasive meaning, is this patient a good candidate for BiPAP? You learn in your disease class, I think they talk about this a lot when they're talking about the different disease states, which diseases are more appropriate to kind of try to make BiPAP work for, which really comes down to your COPD patients. And then when we get to neonatal patients, all of your neonatal patients pretty much. But when it comes to like your ARDS patients, your asthmatic patients, there's not a lot of data to show that there's a benefit of doing a BiPAP trial. So those patients, you'd be more apt to just go, let's just intubate and be done. Pressure or volume ventilation. So pressure ventilation, meaning I'm limiting the pressures applied to the lungs. We've talked about before that pressure ventilation causes less asynchrony than volume ventilation. So that's the advantage of pressure ventilation. So if I'm really struggling with a patient and they're just not, I can't meet their flow demands and they're with volume ventilation, I can switch them to pressure ventilation and they might become quite a bit more synchronous. The negative part of doing pressure ventilation is then I lose a lot of control, that direct control over CO2 removal, which we're going to talk about a little bit later on. Then we're going to talk about whether we want full support versus partial support. So full support of ventilation, it meaning I'm putting them on AC mode. I want to assume the majority or all of the work of breathing for this patient. So I'm controlling how big of the breath, I'm controlling, a minimum, how many breaths they're taking a minute. I'm controlling when the breath starts, when it stops. I'm controlling all the things. Partial support modes of ventilation, these are your SIMVs. This is where I want the patient to assume some of the work of breathing. Then you can go kind of a little bit more into the particulars of modes of ventilation when it comes to the MBRC exams. And I really truly believe for the initiation of most patients, or pretty much any patient when we're just initiating ventilation, I think it's best to stick to like your more basic modes, like your ACVC, ACPC, and then after you've kind of initially stabilized them, then you can look at, the response to ventilation and decide to choose one of these more like complicated or technical modes of ventilation. But I feel like, and I think your book mentions this as well, like when you're initiating ventilation, you don't want to be chasing your tail with too many options. So sometimes it's better to start off really basic and then stabilize the patient, and then you can add these alternative things in a little bit later on. So good news for you guys then. Your choices for picking which mode of ventilation for any of your MBRC scenarios will always just be ACVC, ACPC, or SIMV. So you're not going to be getting thrown in PRVC or any of the other wacky modes. Okay, so then you're going to, depending on which mode you're set, you're going to be having different ventilator settings to set. And then you want to make sure that you have good alarms and backup values. Okay, so your book just talks about establishing an airway. So I think this is an important time to just kind of give you guys a refresher again, a little bit about some of the key points from that chapter 37 in your book. So I think it's important now, if you haven't been doing this, is ET tube size. Make sure you know normal sizes for adult male versus adult female. So typically your males will be, your 8 to 9 for your size. Some references I've seen before say 8.5 to 9.5. But I feel like anything over 8 is an adequate size for an adult male. Okay, for your adult females, you're looking at that 7 to 8 range. Okay. If you're ever given a scenario where the ET tube size is less than 7, or sometimes it's even more accurate to say 7.5 to 8.5. Again, that half size difference, I've seen both of these reference ranges for ET tube sizes. Again, I think if you're being kind of assessed on this information, it's going to be glaringly obvious that it's outside of range. So if you're ever given a scenario on any type of test that says that your ET tube is for an adult, anybody, is a size 6.5, that should give you the alarm bells and say, hey, that's not normal. That is going to increase my patient's airway resistance and their work of breathing. So I need to exchange that tube. That's an important piece to understand. Then remembering too, the other important thing is ET tube cuff pressures. Okay, so make sure you understand 20 to 30 typically is the centimeters of water pressure range for your endotracheal tubes. So if you are intubating a patient and you're doing your assessments of the patient, you want to make sure that cuff pressure is within that range. Okay. And again, if your cuff pressure gets too high, that is an indication that you're going to be occluding those blood vessels, those capillary beds in the tracheal wall, which will result in tracheal wall damage. So you can end up having things like fistulas develop, other esophageal issues being created by those high cuff pressures. So you want to make sure that you're monitoring those appropriately. If you cannot maintain a seal with that cuff pressure of 20 to 30, then you need to reintubate the patient with a larger sized tube. Okay, so that was the big takeaway from that, is if you're using excessive cuff pressures because your tube is too small, you might want to reintubate. Trying to think of what other things. If you don't have enough cuff pressure in there, that can cause you to have those micro aspirations. Okay, so you want to avoid too low of cuff pressures, too high of cuff pressures, keeping within that 20 to 30 centimeters of water pressure range. Last point is just making sure you remember tube placement. So tube placement. This is confirmed with equal bilateral breath sounds. If you hear them on the right but not the left, you should assume a right main stem intubation and withdraw the ET tube. until you hear those equal sounds. You can also be checking for positive end tidal. You should also be checking you can also be checking for like humidification in the tube. And then finally you can, that direct visualization of of the tube going between the cords is another indication of good placement. Finally, you want to get an x-ray. The x-ray should show the tip at 3 to 5 centimeters above the carina. Okay, so tip of the ET tube should be 3 to 5 centimeters above the carina to be in good position. This usually correlates to a marking of somewhere between 21 and 23 at the teeth for men. And 19 to 21 for women. Okay, and those are just kind of like generalizations. Okay, again, the most appropriate thing would be to confirm placement with equal bilateral breast sounds and that chest x-ray. There we go. So non-invasive ventilation, the use of non-invasive ventilation, like I said, should only be considered for very select patients requiring ventilatory assist. We're going to do a whole module on non-invasive ventilation. We'll talk about this more, but just at this point, just understand that really, the major patient population is your COPDers. So more than like 75-80% of all patients getting vent assist are going to get it invasively, meaning with an ET tube. So your choices for, picking pressure control versus volume control, remembering that volume ventilation includes like volume assist control or volume SIMV-VC. Pressure ventilation includes that pressure control, ACPC, SIMV-PC. This also is PRVC actually is kind of classified as a pressure ventilation, even though you're controlling the volume or setting the volume. Volume support too, which seems a little counterintuitive. Because again, it says volume in the name. You wouldn't think that would be pressure ventilation, but how the breaths are delivered, they're delivered to minimize pressures or the focus on minimizing those pressures. So it's considered pressure ventilation. Last week we talked about airway pressure release ventilation. So you should kind of remember that was 2 weeks ago now, that is a very high pressure and a very low pressure. So it's essentially two different CPAPs the patient's receiving. And then your patient controlled modes of ventilation. Those are your assisted ventilation, proportional assisted ventilation, and your NAVA, your neuro assisted ventilation. So full support means that the patient does not require any work again, or does not require any patient work. So the patient can trigger over the simple breaths over what's set, but they're not really required to because their ventilation needs are being met through the settings on the machine. Partial support does require some patient effort. So it implies that some percentage of the work of breathing is going to be expected from the patient and the other percentage is going to be done by the ventilator. So your partial support modes of ventilation, again, are your SIMV, pressure support, volume support, proportional assist or NAVA. All of these are providing some support, but requiring varying levels of patient effort. So picking the type of ventilator really doesn't matter that much in the grand scheme of things. I think probably with your experiences at clinicals of seeing these different ventilators, they all kind of do the same thing. There's not really, I mean, your eyes are all going to have your favorites, but they essentially are all doing the same serving the same function. So I really truly believe that the best ventilator is going to always be the ventilator that your staff is most comfortable with. So I'm a big proponent for, I'm not going to rock the boat. When I was a manager, I'm just like, if we had Puritan ventilators in our facility, when I went to purchase new ventilators, I was going to go with the Puritan Bennett option, unless there was some glaring, obnoxious reason why not to continue a relationship with that company. I was always going to pick, the new version of what we already had, because staff was going to be most comfortable with that machine. You might have noticed this if you've been to clinicals where staff has an option of two different varieties of ventilators, and you'll notice that some staff, no matter what, are always just picking the same one because they're comfortable. Their comfort level with that machine is so much greater than the other machine. So there are some difference, obviously, like different features, different modes that are available, different pressure flow capabilities sometimes, different types of fancy monitors or alarms that are allowed. I think, the Hamilton now is very, very, flashy with all of its bells and whistles and different displays and things like that. Um, Reliability is another big thing. I think that this is the instance of the glaring reason why not to maintain a relationship with the company. There have been instances over my 20 years in respiratory therapy, 20 plus years in respiratory therapy, where, you know, um, the hospital I was working at or the department I was managing, we weren't being supported well by the company that we were using for mechanical ventilators. And if you think about the absolutely astronomical um, budget number that is required to purchase all of those ventilators, you feel like, hey, we deserve some really good customer service. Um, there was once where we had an issue. One facility that I knew of had a really big issue with their ventilators failing. They bought all these new ventilators and their ventilators kept failing on them, and there wasn't tech support to come out and fix them. So they had all of these very, very expensive decorations in their storage room. So that would be another reason to kind of choose a different ventilator. Um, and again, we're focusing more so on just those initial settings being based on the patient's clinical presentation. So, okay, so back to choosing our modes and advantages, disadvantages of these things. So assist control ventilation, we're talking about assist control. You have two options. You have your volume ventilation up here, your pressure ventilation down here. So the advantages of volume ventilation include, it ensures that minimum safe level of ventilation. Patients can increase their rate above the set. Disadvantages, though, is if you're not careful and the patient is dysynchronous, this is very, very susceptible to flow dysynchronies. Um, the patient can have a lot of increased work of breathing. So advantages of pressure ventilation, ACPC, is that you have those variable flows, which ensures that you kind of are controlling a little bit more of those plateau pressures. They have kind of a more sustained inspiratory pressure that actually can result in a reduction of mean airway pressure sometimes and improvement of that gas distribution. But the disadvantage of that is, I'm sorry, not decreased mean airway pressures, increased mean airway pressures. So that helps improve the gas distribution, but you have higher mean airway pressures. You can have variations in those tidal volumes, which can result in hypoventilation and acidosis. So this is where this chapter, this is why it was so confusing when we were talking about control mode ventilation. Earlier in chapter 46, where I felt like the book was very confusing because true control mode the patient cannot trigger the breath, which, this chapter really does a nice job of spelling out. So when you were talking about modes, and I mentioned this when we were talking about modes before, there's ACVC, which is the patient's, it's a full support mode. The patient gets a set rate, set tidal volume, but the patient can trigger breaths over that set rate. In control mode ventilation, true control mode, the patient is not able to trigger any breaths. So the patient is only going to get what you set on the ventilator. So to be in a control mode of ventilation, really the patient needs to be paralyzed. We should avoid using this mode of ventilation pretty much at all costs. There's very, very little benefit to using this mode of ventilation. So the advantages, though, is it completely eliminates worker breathing because the patient can't do anything. We have total control, so we can do inverse IDE ratios, meaning I can have this very long inspiratory time, which allows for, again, better oxygenation. But I need sedatives, which really most often you either need very high levels of sedatives or most often you're giving a paralytic, which is not advantageous to our patients' outcomes. The use of a lot of paralytics and a lot of sedation in our ICU patient population is linked to increased mortality rates. There's been a lot of studies that have talked about that. Intermittent mandatory ventilation, this is your SIMV. Again, the benefits of this may be used for partial or full support, can be used in volume or pressure, but typically we're doing this for volume control, not pressure control. So this is a combination of those machine breaths, means that it's can be time or patient triggered, but it's machine cycled, so it's time cycled. And then it has spontaneous breaths. So the pressure support's used during those spontaneous breaths to decrease the patient's work of breathing. Again, spontaneous breaths are breaths that are triggered, have to be triggered by the patient, have to be flow cycled by the patient, meaning that once the vent senses reduction in the flow rate, patient's expiratory flow rate, or inspiratory flow rate, excuse me, it will cycle into exhalation. Most studies have shown that there used to be that we would, there would be big proponents of using SIMV and weaning on SIMV and doing that as like kind of an adjunct to getting the patient off the ventilator. But again, most studies show that using an SIMV isn't benefiting the patient and it's actually delaying the extubation. So it's better, as you guys have probably seen in all of your clinical weaning trials, if you watched a patient go through daily weaning trials or spontaneous breathing trials, we're not putting them to SIMV. We're just switching them to pressure support of 5/10 and extubating from that. Pressure support ventilation, again, recapping, this is assisted spontaneous breaths. So the patient has to initiate the breaths, end the breaths through their effort. All we're doing in pressure support ventilation is giving them a little bit of boost. So we're just giving them a little bit of pressure, just like they would get in if they were on BiPAP, to help them out, help them achieve good spontaneous tidal volumes, reduce their work of breathing, especially when you think about the fact that they are intubated, they have to suck through that straw of an ET tube. So giving that little bit of pressure support will help with that. Airway pressure release ventilation allows for that spontaneous breathing. So it's using those high and low pressures really for kind of a recruitment technique. So APRV is very beneficial in patients that have poor lung compliance, and poor oxygenation. High frequency oscillatory ventilation. This is used when you want to use very, 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 very fast respiratory rates with very small tidal volume. So small tidal volume so small that it's pretty much the same as anatomic dead space. So we talk way more about oscillatory ventilation when you get to NeoPeds class. I try to not focus on it too much in life support just because I've got all kinds of other stuff to be focusing on right now. So we kind of save this one for NeoPeds a bit. So it talks about, your book does talk about how that gas, even though that you're using this small anatomic dead space, this gas gets transported through a couple of physiological effects like bulk flow, the Pendelift effect. Those are the big ones, molecular diffusion. That will, we will talk about that in your neopeds class next semester a lot. Big takeaway with adult use of high frequency ventilation is that it's really not been shown to be superior to conventional ventilation in a lot of scenarios. My theory is that it usually is due to, again, RT comfort. If the only time you ever use a machine is when the walls are crashing down on you and your patient's doing really poorly, that's probably not the time to try to figure out how to best use these machines. You want to have at least a good baseline comfort with them first. So I think that runs why it's very, very difficult to prove that oscillatory ventilation works, just because people aren't as comfortable with it. Clinicians, I mean. High frequency kind of includes like oscillatory ventilation, which we use a lot in like RDS infants, but they also have high frequency jet ventilation. This has been shown to be pretty effective in like large air leaks situations like pneumothoraxes, or trying to ventilate lungs that have big leaks in them. All right. So now the exciting stuff. Initial setup. So you're going to be picking a tidal volume, and you're going to be picking a respiratory rate. So how do you pick these things? Okay. The tidal volume should fit between the ranges of 4 to 8 milliliters per kilogram. Ideal body weight. So we did the calculation for ideal body weight previously, where I said it was this guy. So 50. Ooh. I'm always doing that. Actually not gonna draw. This thing does not work well for drawing. So for male patients, male ideal body weight equals 50 plus 2.3 times their height in inches minus 60. Okay, and this gives you ideal body weight in kilograms. Your female ideal body weight in kilograms is going to equal 45.5 plus 2.3 times their height in kilograms minus 60. Okay. So that's how you calculate that ideal body weight. Then you just need to decide whether you want to multiply it by 4, 5, 6, 7, or 8. So typically initial tidal volumes should be for like average normal adults, anybody that doesn't have any acute restrictive disease. So remember, your restrictive diseases are the ones that cause low volumes or poor compliance. So for most of our patients, you're going to be picking 6, 7, or 8, okay, with a respiratory rate of anywhere from 12 to 16. Okay. For patients that are sick with ARDS, you are going to want to pick tidal volumes within that 4 to 6 range, that low tidal volume strategy. There are references out there that say that you can use up to 10 milliliters per kilogram, and in certain situations, the patient might be demanding 10, and that's the only way you're going to make them happy is to give them 10. But after you get above 10 milliliters per kilogram, there is a lot of documentation that demonstrates that those volumes lead to a lot of lung injury. So never, ever, ever more than 10. After initiation of ventilation, you can adjust things down. So you're going to look at your tidal volume after you put the patient on it. And then I want to make sure that I'm maintaining that plateau pressure less than 30 and a driving pressure less than 15. So let's give a scenario here. So say I have a patient who, is just a post-operative patient. So no history, just regular guy, post-operative, coming back to the ICU, and I need to put them on the ventilator. So I'm going to pick 8 milliliters per kilogram, ideal body weight. So the patient is a male. So I'm going to be using this equation. And he is 6 feet tall. So that's 72 inches. So again, I know that 6 feet is 72 inches. But if you didn't know that, all you have to do is know that 1 foot is 12 inches. So 6 times 12 is 72. That's how I get that number. So I'm going to plug the 72 into this equation. Okay, remember math. So math rules. Math does rule, but math also has rules. 72 minus 60, which is 12. So I do parentheses first. So this PEMDAS, so parentheses, exponents, multiplication. So now I'm going to multiply by 2.3, 12 times 2.3, which is 27.6. Okay, then I'm going to add 50 to that, which gives me 77.6 kilograms is what this patient's ideal body weight is. I said I wanted to start at 8 milliliters per kilogram, so I'm going to multiply that by kilograms times 8 milliliters per kilogram, which equals 620.8 kilograms, or excuse me, not kilograms, milliliters. Okay, I'm just going to round down because I like nice clean numbers, and I'm just going to call that 620. Okay, so there I am. I'm within my 6 to 8 milliliters per kilogram. I'm going to start there. Put the patient on that, and let's just say, because this is a normal, regular guide, I'm going at the top end of the tidal volume range. I'm going to pick the low end of my respiratory rate range. So let's say I'm going to pick a respiratory rate of 12. So tidal volume is 620, respiratory rate of 12. I plug that into my machine. I do my assessment of my patient then. Okay. It's always super important that whenever you make any vent changes whatsoever, you are reassessing your patient. Okay. I see this a lot. Probably been guilty of it before as well, where you're in a rush, you get a new setting change. The doctor says, oh, decrease the rate to 12, or, oh, increase the rate to 16. And you run in the room real quick, you plug it, you turn it up to 16, and you run out and you just document respiratory rate to 16. Okay. You guys all should know by now that by changing that rate, I'm changing other things about that breath delivery to the patient. I need to take a minute and make sure that there were no negative side effects or negative impacts to the patient based on that increase in rate. Okay, just like this scenario, I decided on these settings, I need to then put the patient on them and see if there's any negative impacts. So what negative impacts am I looking for? I'm looking to make sure that my plateau pressures are less than 30. Okay, so if I come over to my patient and I'm doing my assessment and my plateau pressures on these settings ended up being 35 for whatever reason, and I could go, whoa, 35, ugh, that's not good. So what do I need to do? I know I need to decrease my tidal volume, okay, to get this plateau pressure within a reasonable limit. So let's say then I go, okay, so that didn't work. Let's decrease him down and let's put him on 7 milliliters per kilogram. So I'm gonna 77.6 times 7 gave me 543. So I'm gonna decrease his tidal volume to 543. Okay. Now I've done that. What's that gonna do to my ventilation? I had 620 times 12, which gave me a minute ventilation of about 7.4. Now I have to maintain that same minute ventilation of 7.4. Now I need to, if I divide that by my tidal volume, I see that my new respiratory rate should be somewhere between 13 and 14. I'm going to round up and change my respiratory rate to 14. Okay, I probably should do that math out over here and not just jump to conclusions for you guys. Okay. All right, so initially my minute ventilation, which is what affects how much CO2 gets out of my lungs, was 620 times my respiratory rate, which is 12. Okay, which gives me a minute ventilation of 7.4. Okay. I decreased my tidal volume to 543 to try to improve my decrease my plateau pressure. So now I need to figure out what my new respiratory rate should be to maintain that same minute ventilation that I had before. So I can do this. I want the minute ventilation of 7.4. So 7.4 is going to be equal to 543, which is my tidal volume, and which I should put it in liters, so 0.543. So that's in liters, because this is in liters per minute. Okay. And then I'm going to multiply by X, because I don't know what I'm going to solve for X, because I don't know what my respiratory rates needs to be. So in order to solve for X, I have to divide this side by 0.543 liters, divide this side by 0.54 liters, and then I will get X. So 7.4 divided by 0.543 equals, it's like 13.6. So I'm going to round up and say my new respiratory rate should be 14. All right. We did this in lab today, so hopefully that is clear. Okay. Initial setup. Moving on to talking a little bit more about excuse me. Trigger sensitivity. So remembering trigger sensitivity is set to determine how hard or easy it is for the patient to initiate that breath. So it needs to be, we don't want our patients to work too hard to just even ask for a breath. So it needs to be set the least amount possible while still avoiding auto triggering, meaning that is just believing that the patient is triggering and asking for breaths when the patient's really not doing anything. Okay, so most ventilators either allow pressure triggering or flow triggering or both. It used to be with how ventilators used to be designed, flow triggering was much easier, had been shown to be easier for patients to do, but now I don't think that's true. Just kind of be aware of which one you're using, because there's going to be different, like, kind of optimal ranges to be kind to fit within. There are going to be some factors that are going to create trigger asynchronies as well. So if I'm using really big tidal volumes, that can cause trigger asynchronies, or if I have that sensitivity set inappropriately. If I have some auto PEEP on board, that can cause trigger asynchronies. If I'm using too much bias flow through the circuit, the ventilator circuit. So I don't know if everybody knows this at this point, but there's constant flow going through your vent circuits. There's never a point where the flow is completely turned off to zero. Most vent circuits and ventilators use what we call a bias flow, which is that continuous flow through the circuit of a minimum of usually 2. So that means that during inspiration, I'm going to be, giving them 60 liters for their flow rate, inspiratory flow rate. And then when we go down to exhalation, Obviously I'm going to be giving some flow to maintain that PEEP, but that flow also is helpful for always having flow available for the patient for breathing rather than having to suck through the whole entire circuit. And it also helps, especially when you use like heated wire circuits. Like if you didn't have constant flow going through there, you'd be melting all your plastic. Abdominal paradoxus, again, like how the patient's breathing, whether they're using their abdominal muscles or the respiratory muscles, can cause some ventilator asynchronies where the patient's not getting the breaths that they're asking for, which looks like this. So I'm gonna see if I can function and draw here for you guys this time around. So a lot of times you see these trigger asynchronies. No. No, it does not. It just really hates me. Oh my Lanta. Now, all right. All right. So here's a couple examples of how you can have these asynchronies with triggering. So here in this first on this first breath here, you see this negative depression there, which we've talked about before, being the indication that the patient's asking for a breath. Only the patients can draw in negative pressure. So the patient's asking for that breath and they get a breath delivered. So that is a synchronous breath. The next breath here, you don't see that negative dip, meaning that that is a mechanical breath. It's timed by the ventilator. The patient had to take it. They got given it. After that breath, you notice a little depression there, and then followed by another little depression, but no breath attached to either of those. Those are patient effort without a subsequent breath, meaning that the patient, my sensitivity is not set low enough for my patient to get the breaths that they want. So this can lead to a lot of agitation, increased needs for sedation, increased work of breathing. Okay. Okay, the next thing your book kind of talks about is inspiratory flow time and that IDE ratio for volume ventilation. We have covered this quite a few times already, but this bears repeating, and I know some people are still a little foggy on it. So most ventilators allow the clinician, to select like a peak flow rate, a tidal volume, and usually a respiratory rate in volume control mode. Or if they're not allowing us to set peak flow, they're allowing us to set inspiratory time. Okay, so I'm either setting flow or time along with the volume. Okay, and then I can derive the other things. So typically for adults, if I can set an inspiratory time, I usually want it to be around 0.8 seconds. Okay, that is considered kind of normal for an adult. You can go anywhere down from to 0.6 up to 1. But I'm looking to set an inspiratory time to allow for enough time for exhalation. And typically for most of normal adult patients, that's usually a 1 to 2 ID ratio, meaning that I'm spending one part of the time in inspiration and then twice as long for exhalation. So there's 3 parts total. So if I'm setting an inspiratory time of 0.8 seconds, if I have a tidal volume of like 500 milliliters, that is going to result in a flow rate. That's going to generate my patient's flow rate. Okay. Once I plug those in, and kind of again, you're just kind of guessing a little bit. You're going to be setting something within a normal range, but you are not going to know if that's appropriate for the patient until after you set it. Okay. So what you need to look at after you set your flow rate and when you're doing that initial vent check is I always look at my pressure waveform. Okay. When I look at my pressure waveform should look like, sees the kind of the picture or the scalar that's on the left hand side of the screen. Okay. See how it's kind of rounded upward on the left side of the peak. Over here in the second example, you see that this side of this peak has gotten quite flat, and in severe cases, it can get a little concave where it ends up scooping in like this. In really bad cases, get my little drawer tool out again. Let's see if I can struggle again with this. So if it's worse, it looks like this, where it's really scooped out. And sometimes I've even seen it so bad as it looks like this. Change colors here. Okay, if you ever see this on your pressure waveform, this is a huge big red flag, and it's just like this patient wants more flow. Because what's happening here is this patient, could have triggered this breath if there was a little negative depression down here. But what's happening is that they're getting this breath, but if they're getting enough, they're not going to be making much more effort throughout the delivery of this pressure. But if they're not getting enough, they're going to start trying to keep sucking in, keep triggering the breath or the ventilator to try to give them more than what the ventilator wants to give them. So they're going to be creating more work of breathing. They're going to be creating more negative pressure in their chest to try to initiate more flow. And then that negative pressure from the patient causes this dip in that pressure waveform. So that's that patient effort. So the bigger the dip, the more the patient's trying to make an effort because they're not getting enough from the machine. Hopefully that makes sense. We'll look at that, too, as well in lab. Okay, so in this chapter also has a very nice chart on page 1083 for you that goes through tidal volume, peak flow, rate, determining inspiratory time, expiratory time, and ID ratio. So here, I made you guys do this on a worksheet before. Here, the book's doing it for you. I didn't want you just copying from the book. I wanted you to think about it because, again, this is not something you should memorize. This is something you should understand so that you don't have to memorize it. So as tidal volumes go up, okay, as I increase my tidal volume, I'm going to need more time for that tidal volume to be delivered, okay? So then I have less time for expiration. Okay, as tidal volumes decrease, I need less time for less inspiratory time. My expiratory time will increase. Okay, if my peak flow increases, my I time gets shorter. If peak flow decreases, my I time gets longer. All right, so that kind of gives you kind of some of those scenarios. All right, and then it goes kind of on to like a second part with B, which it talks a little bit about the effects of volume, inspiratory time, and rate on inspiratory flow, expiratory flow, and that ID ratio. So I feel like that's a nice visual. Again, make sure you just understand the information in the chart. You don't have to memorize it. This is what I was referring to when I said you can't just go into the patient's room and increase or decrease the tidal volume or increase or decrease the rate without looking then at the patient to make sure that didn't have a negative impact on the flows that they were getting, so that now all of a sudden they're having a flow dysynchrony, or that it didn't have a negative impact on the amount of expiratory time the patient had and they're having like generating auto PEEP. Excuse me. Talking about flow waveforms again, common choices are either your square or your down ramp, which is your decelerating ramp. Big takeaways again, always is that square waveform may be more useful in reducing mean airway pressures in patients with severe hypotension. So square waveforms actually, even though they have higher pips, they have lower mean airway pressures. If you use the decreasing or decelerating flow waveform, the goal is to optimize the distribution of inspired gas and improve oxygenation. This is going to require lower pips, but does have higher mean airway pressures. That's all you need to understand about that. Okay, don't get too deep in the weeds with it. Inspiratory pauses were something that we used to do a lot more. This is something that we used to set when we didn't have a fancy mode options. See how old I am. This is a function on some ventilators that allows for a brief hold at the end of inspiration. So at peak inspiration. So if you do it kind of with me, where you're taking a deep breath and I'm holding my breath for like 0.2 seconds, and then I'm going to let it out. This may improve distribution of ventilation and oxygenation because I'm holding my airways open at that peak inspiration. It's really not been shown to have enough benefits to, warrant the risk of the side effects, which is increasing your mean airway pressures. I'm doing that inspiratory hold. That can have a negative impact on venous return. We also used to do this whenever we gave bronchodilators. I remember back in the day when I would be trying to give an MDI and I wanted to be like Mr. Fantastic from Marvel, where I could stretch my arms really long. So I'd be trying to give the MDI with one arm, but also reach the ventilator with the other to do the inspiratory hold button while I was giving the MDIs to try to help with bronchodilator delivery. Again, now we kind of know better that isn't necessarily demonstrating a better delivery. It kind of made sense that it might, but they did studies on this and it did not show any significant improvement in bronchodilator effectiveness to do the monkeying around with trying to do the breath hold. The other reason that you might want to do it is we do it purposely to obtain plateau pressures, right? To get our the numbers necessary to calculate out compliance and airway resistance. But the only other reason you potentially would want to do an inspiratory pause is like when they come in to do their chest x-rays in the morning, you might want to do an inspiratory hold so that they can get the x-ray at peak inspiration so that the lungs don't look underinflated. Looking at oxygenation. So FiO2, if you're ever unsure of where you want to start with your oxygen, just start at 100% and then just know that you're going to be rapidly titrating it down to achieve the optimal SpO2. Okay. The only times where I would say that it's appropriate to start on less than 100% is if you have a previous gas that shows that the patient's oxygenating well on something less than 100. If the patient's kind of stable, they don't have any like respiratory history that shows that the patient is in severe hypoxemia. If the patient has known diseases that are responsive to oxygen, so diseases that wouldn't cause like a shunt. So if it was like a COPD, you would assume that they're going to be responsive to oxygen. I wouldn't think that I would need to use 100% on a COPD versus this is a pneumonia patient that I know that that's a shunt. I know that this patient's probably not going to necessarily respond well to oxygen. I'm going to put them on 100% then. So if you, like I said, if you know that they can tolerate a lower oxygen FiO2 or oxygen concentration, you can start them on somewhere between 50 to 70%. I feel like on the MBRC, they either give you the option of starting them on 100 or starting them on 60. So they make it pretty black and white for you. So patients in this category would be like your postoperative patients, COPD, emphysema patients, drug overdose patients that don't have any indications of aspiration, neuromuscular disease patients, or post-op patients with pretty normal lungs. Again, you're going to be closely monitoring the patients, and you're going to be wanting to wean this quickly. When we talk about adjustments, if I start a patient on 100%, I'm going to be rapidly weaning that. Like, I started at 100%. I'm going to wean them to 80 as long as their SATs tolerated. My next wean is going to be down to 60. My next wean will be down to 40. And then once they get to 40 and they look good on 40, then I'm going to stop. And then any future adjustments will be within 5 or 10%. But when we say rapid weaning, we're saying like you're really drastically reducing the amount of oxygen that you're giving the patient fairly quickly. Okay, PEEP. So initially PEEP, initial settings of PEEP are easy because usually you're picking 5 a PEEP. So that's usually, a lot of times people consider that like physiologic PEEP, like patients need a minimum of 5 a PEEP. Higher PEEPs are though used to improve and maintain FRC and oxygenation. So if you have a patient that has issues with oxygenation due to shunting, or they have different issues with keeping an FRC due to like poor lung compliance, you are going to probably need to use higher than 5 of PEEP. So sometimes, 8, 10, 12, 12 of PEEP. None of those numbers are necessarily abnormal. With setting PEEP or using higher PEEP, we're going to talk about optimal PEEP settings. So you're going to be adjusting your PEEP to give you the best oxygenation, best compliance without negatively impacting venous return and cardiac output. And I have a couple examples of this, so we'll talk about that when we get to those slides. I think that's going to be in the next slide deck in part 2. We'll go through the examples so this becomes less scary. Your book talks about open lung strategies or recruitment maneuvers in PEEP. So ARDS patients, again, these patients require high levels of PEEP. Typically in ARDS patients, you're combining that with low tidal volume strategies. So typically those patients have tidal volumes of 4 to 6 milliliters per kilogram per actual body weight. You might also be initiating these lung strategies. Obviously if I'm only using 4 to 6 milliliters per kilogram, I'm not going to be, my minute ventilation can sometimes be lower than what I would need it to be to remove the CO2. But in our ARDS patients, I'm going to talk about this more later, we use something called permissive hypercapnia, meaning that I know that your CO2 is not what we want it to be, which is causing your pH to not be where we want it to be. But I'm okay with that because in order for me to try to get your pH normal, I would have to apply way too much pressure to your lungs, which would cause further complications. All right, so lung recruitment maneuvers. These are intended to open up those collapsed units, and then usually after we do the recruitment, we're gonna kind of set PEEP. Like we're gonna gradually lower our PEEP back down until we notice negative impacts on oxygenation to tell us this is the PEEP we need to keep our lung alveoli open. And again, that will make more sense in the next lecture when we talk about adjusting PEEP, and I will show you how that actually looks on different graphics. It's not as scary as you think it is. So one other setting that some ventilators have in like your pressure control modes is pressure rise, which just really is talking about how quickly we reach that peak inspiratory pressure. So here we're reaching early on. I'm progressively having a lengthened rise time. But if you notice that, I'm lengthening my rise time. It's taking me longer to reach my peak inspiratory pressure. So now instead of kind of having this square pressure waveform where I'm maintaining that same pressure control throughout the entire breath here. When I get to back here, it almost looks like it's ascending, like I'm starting at a really low pressure and I don't hit my peak pressure until the very end. And if you notice the impact on the tidal volume, my tidal volume gradually gets, oops, no, that's my tidal volume, this is my tidal volume. My tidal volume gradually gets smaller as I lengthen my rise. So this, again, I feel like a lot of times we're not monkeying around with this. This could be beneficial to patients if there is, you know, really, really high airway resistance also, because again, you're seeing with a reduction in volume, you're seeing that reduction in flow rate. So it can be helpful in overcoming airway resistance issues, but inspiratory airway resistance issues, but that's the only really benefit I can think of. Limits and alarms. A big important thing to understand about this is alarms must be set tight enough to warn about problems without being a nuisance. So there is a table in your chart. I'm not saying memorize this table. I'm just referencing it and saying, look at that table a little bit to get kind of an idea of what they recommend for where you want to be setting your pressures or your alarm limits. Finally, humidification. Your book talks about when you're setting up ventilators or initiating ventilation to consider humidification needs. So heated humidification or HME should be provided to all patients. All patients that are on mechanical ventilation need humidification because we're bypassing the upper airway. So HMEs are perfectly fine for patients who don't have secretion problems, or patients that have like a low body temp due to cooling, have don't have high spontaneous minute ventilation, or patients that have like big leak. So you can use HMEs in any patients that don't meet any of those criteria. But really, truly, I would instead of thinking of reasons not to use them, I think it's easier to memorize that HMEs are really only going to be used in those kind of post-operative patients or patients like that are you're expecting to wean and extubate quickly, because long-term HME use really isn't as beneficial as heated humidification. So I think the better thing to kind of think about with humidification when it comes to mechanical ventilation is not looking at contraindications for HMEs, but just thinking there shouldn't be used on anybody that's going to be on the ventilator longer than 24 hours. And if they're on the ventilator less than 24 hours, but have a lot of really thick secretions or have a really, really high minute ventilation, those HMEs are not going to be able to keep up with the patient demand with that minute ventilation, and they're not going to be able to meet the humidification demands of those thick secretions. So putting them on the heated wire is better. I have had that happen to me before where I've switched a patient over that was on an HME for days, and then all of a sudden I switch them over and they're on the heated humidifier and everything just starts pouring out of them, and the nurse will complain and be like, oh, we need to take them off this. Now I'm suctioning them all the time. I'm like, we're suctioning them all the time because we just rehydrated all the cement that had been in his lungs because that HME wasn't doing its job. So just something to think about with humidification. Okay, come back for part 2. Again, I think you're gonna be better off waiting, especially with part 2, waiting until next week, the following week to view that lecture after lab.